All right, we're back with Communications, Chapter 4, Part 2 of 3. So now we're going to talk about our EMS communications, both receiving and while we're responding. So some of the reasons to communicate with dispatch: for the location of the call and information. They're going to give us that information. Now, with the computers nowadays, sometimes there's printers inside the ambulances. There's printers in the station. It spits out a run form, or not a form, but a run sheet that tells you the location, the address, possible what the problem might be. And then when we're en route to the scene, and then we communicate when we're out at the scene with dispatch, whether it's verbal or whether it's pushing a button on a computer. Then we're also going to be communicating with dispatch when we're en route to the hospital, when we arrive at the hospital, and when we clear the hospital and become available. These are all times that we would be communicating with dispatch. So it might sound something like this. Dispatch assigns you a call, and they'll call your unit. Medic 111, copy call. Your response would be, go ahead. Dispatch might say, you have a call. Your call is a priority 1. Difficulty breathing at 2400 Cypress. MAPSCO 77G. Cross street is Presidio. Timeout 2143. All time in the fire and EMS service is based on military time. You'd respond, Medic 33 received, or Medic 111, I'm sorry, received. Medic 111 on scene. Dispatch would then tell you the time, received at 2150. Dispatch, this is Medic 111. We're going to have a priority 3 patient, code 1 to Parkland Memorial Hospital. Dispatch would then tell you received at 2157, which lets you know what time you're en route to the hospital. Medic 111 is out at Parkland, and dispatch then says Medic 111 received 2200 hours. So we talk to them en route to the scene, when we arrived at the scene, when we're back en route to the hospital, when we arrive at the hospital, and when we clear the hospital and become available. And we do have some other reasons to communicate with dispatch. When en route, dispatch advises you that there's multiple patients. Consider maybe putting a helicopter on standby or an additional ambulance to proceed non-emergency to your scene. The thing there is, if you call for extra units or a helicopter, if you figure out now you don't need them, make sure that you disregard them prior to their arrival on scene. If dispatch advises you your scene is violent, involves violence, such as a shooting, stabbing, or assault, and the actor's still on scene, stage for PD. Let them make the scene safe. This means don't go driving up into the middle of the scene. Wait until the police have secured the scene before entering. And if you are responding to the scene and you're delayed, state Medic 111, we have a delayed response due to being caught by a train, and advise dispatch when you've cleared the delay so that they can mark the time and you can continue on to your scene. Talk a little bit about on-scene therapeutic communication. And it's It's really, really simple. The sender, this whole communication, therapeutic communication model revolves around the sender taking a thought. They have to encode that thought that they're thinking into a message. And then they have to send the message to the receiver, to the person receiving it. The person receiving it then has to decode the message and then send the feedback back to the sender that originally sent the message. It's a very simple process, except in the EMS and the fire service, one thing that you've got to take into account: noise. You're in the back of the ambulance, it's not exactly the quietest place in the area. If the sirens are going, it's going to sound inside the back of the ambulance. You can't help it. It's loud. You have road noise. You might have patient noise. They're talking or crying or screaming. And as you send these messages out, are you able to get that message across to the receiver? And is the receiver going to be able to decode that message correctly with all the background noise? And if they don't decode it correctly, then there's going to be stuff that's lost in the whole communication process, and then you got to start it all over again. So just remember that in this business, we've got to deal with noise a lot of times in transmitting and sending and receiving communication. Some other things that you come across: age and culture. It shapes how a person communicates. Either age, culture, and personal experience, body language, and eye contact greatly is affected by culture, because in some cultures, direct eye contact is impolite. Our culture, for the most part, is we look at each other in the eye when we're talking to them. Some cultures aren't that way. If you know the culture in the district that you're working, it'll make it simpler. But if you don't, you're going to have to kind of learn how to adapt and overcome. And in other cultures, it's impolite to look away while speaking. So it just comes with personal experience and knowing your district and the type of patients that you'll be dealing with. Your tone and pace and volume of language reflects the mood of the person and perceived importance of the message. Anthropocentrism, considering your own culture values more important than those of others. We can't do that. And then cultural imposition, forcing your values onto others. That's not what we're there for. We are there to help the patient that's having, at that particular point, because you're there, having the worst day of their life at that particular moment. Think about body language providing more information than words alone. The facial expression, body language, and eye contact are physical clues. And you've got to watch your own body language and facial expressions also. Because remember, the patient's looking at you, you're looking at the patient, and they might perceive your facial expression or body language as not caring, not concerned with what's going on. And looking at facial expressions and body language can help people understand the message that's being sent. Some other physical factors out there: noise, and anything that dampens or obscures the true meaning of a message. When we're asking questions, we can ask open-ended questions that require some level of detail. That's the kind of questioning we like to use. We try to use open-ended questions whenever possible. An example of that would be, what seems to be bothering you today? On the other side, there's closed-ended questions, and they can be answered in very short responses. And a lot of times the response is a single word: yes, no, maybe, okay. We use this if the patient can't provide long answers. Think about that patient that has 1 to 2 word dyspnea. They can only answer 1 or 2 words in a sentence. And then it's very choppy because they have to take a breath. That's a time that would be a good time to use closed-ended questions, yes and no. And a short yes or no question is, are you having trouble breathing today? Simple yes or no can give us the information. Talk a little bit about some interviewing techniques. When we're interviewing that patient, consider using touch to show caring and compassion. Use it consciously and sparingly, and we're going to avoid touching the torso, the chest, and the face. You can touch their hand, you can touch their shoulder. I mean, it's not wrong, but you need to be very careful. You don't want to cross a line. This works real well with the elderly patients and the kiddos. Those in between, you have to be very, very careful with, because they could misconstrue that of your compassion and caring for the patient of being one of an advance on the patient. So be very, very careful when using touching. We want to make sure that we use good eye contact and make frequent eye contact with your patient. It shows that you're interested in your patient's well-being and that you're paying attention to anything that they're saying. If you don't make eye contact, it gives them the impression that you're uneasy around them and you lack confidence. But also remember, be aware that in some cultures, making eye contact is considered rude. Be aware of your body positioning and body language. If you're higher than your patient, you're standing above your patient, you may appear intimidating. Think about that little 3-year-old or 5-year-old that's hurt, and now you're towering over them. You're already taller than they are, but now you look like a giant to them. Get down at their level. It's so true with children. Get down there to their eye level. Don't tower over them. Think about the elderly patient is sitting in a chair, like in the picture, or laying down in bed. Get down to their eye level. When you crouch down, it does make a difference. It reduces the size difference, of course, and greatly improves our communication with them. If you remain standing and crossing your arms and not directly facing your patient, that's going to send them a message of what? Correct, that you're not interested in the patient. Crossing our arms does have a time and place in dealing with a prospective, possible dangerous or uncooperative patient, but you're only going to use that very frequently. With pediatrics, most of the time it's best to get parents involved with communication with a child. But certain age children can give you information. And if you have real young kids that are in the parent's arms and you've been dispatched to the patient, you can leave them remaining in the parent's arms or on their lap while you examine them, because it gives them a sense of security being with mom or dad. We're going to use the patient's proper name. If the patient's older, and refer to them as Mr., Miss, Mrs. Show them respect. Act and speak in a calm, confident manner. Be honest. Tell them the truth. If it's going to hurt, tell them it's going to hurt, and especially with the kids. Because remember that this may be the first time they've had any interaction with an EMT, especially with a child. So your part of your job in being a patient advocate is you want to try to make it a positive one for the child. Be honest with your patient. Be cognizant of the patient and family members' feelings. Be careful, because you can be too honest sometimes, and that's not a good thing. Don't use phrases such as, he'll be all right, or she'll be all right, because this a lot of times triggers your patients to suddenly think about cardiac arresting and dying. Or if they do, you tell them, oh, they're going to be all right, and next thing you know, they're not breathing. You have family members there. How are they going to take that? Don't lie, because kids, they can pick up faster on a lie than an adult. And one of the other things that has starting to happen a lot more is with CPRs. We allow the family to remain in the room. It helps them, aids in their understanding and belief that everything possible is being done for their loved one. That's fine, but if you have somebody that's acting out, that's in the room, you're going to have to get somebody to get them out of the room, because they're going to become more of a hindrance than a help. Here's the big one. Best interviewing technique you can have is to listen. And listening is an active process. It takes practice to become a good listener. Allow the patient enough time to answer each question that you are putting out there. Remember that some patients have disabilities that can impair their communication, their hearing, and their seeing. If your patient has a hearing disability, they're going to benefit from being able to see your lips move, and it helps them understand to understand what you're saying. Be sure a hard of hearing person can see your mouth move when you talk. And don't assume that the geriatric patient is hard of hearing or too confused to think clearly about their answers. You may need to kneel down closer to your patient's ear and speak louder. But don't talk down to them when you do. There's a difference of talking louder and going, well, come on, come on, you know what I'm saying. There's a big difference between those two. You might have a visually impaired patient. Visually impaired patients can hear. Yelling at them is not going to make them see any better. You're talking a normal voice to the uh, visually impaired. Don't yell at them. It's not going to change their eyesight. Take extra actions to explain, extra effort to explain the actions that you're going to take with the seeing impaired patient. About non-English speaking patients, somehow, some way, you need to find a way to obtain medical history. Maybe the patient speaks some English. One of the ways to get this is to use short, simple questions. Point to different parts of the body. Have a family member or friend interpret. And if you're in an apartment building, or where there's a lot of kids, the 8, the 10, the 12-year-old kid, great interpreters. The thing about using a child as an interpreter is do not use $3 medical terms with them. That little 8-year-old doesn't know. You can use the stomach. They might not quite understand stomach, but if you say tummy, they have a good grasp of what the tummy is. So this is the end of part 2 of 3 parts of chapter 4, communications.